This is the Level 4 AAP Primary and Secondary Survey Assessment. Present for this is Martin Yates, CEP, and
Nathan Hughes, Apprentice EMT1.
Okay, Nathan. As this is your assessment, you have to go ahead with this today.
I am.
Okay. So the aim of this assessment is to demonstrate your skills in primary and secondary survey. So that's what we'll be looking at. Okay, so you are working on a dual crewed ambulance as part of a 2-tech crew. You've been called to a 45-year-old who has been found unresponsive in a car park. There are no witnesses and there's no one that can give you any detailed medical history when you arrive. Your assessment will start when you approach the patient.
Okay, so on approaching the patient, I'm going to ensure that I've got the correct PPE on for the circumstances. Bearing in mind we're in a car park, that PPE may well include now a high visibility jacket so that I can be seen potentially working amongst vehicles and moving traffic. I need to make sure the scene's safe, and I'm looking at my approach to the patient and my egress from the patient. I'm taking into consideration members of the public moving around me, vehicles that might be moving and reversing, and potentially using maybe members of the public just to secure my surroundings whilst we work with the patient.
The car park has been closed, so it's safe to approach. There's nobody really knocking around.
Perfect. On my approach to the patient, I'm going to get some early indication really to their responsiveness, how they're lying, looking for any sort of method of their injury, how they've ended up being on the floor. I'm looking at their general presentation, their pallor. Can I see early indications of a chest and rise fall?
So as you look at the patient, they are lay as they are, just in an open space, lay where they are. They are pale in colour. They look a little bit sweaty. However, there's no obvious signs of any cat hair or mechanism of injury, and they do look like some work of breathing as you're looking at them.
Smashing. So there's no obvious signs of blood on the floor. So they're not responding to me, so I'm going to just approach the patient and say, "Hello, buddy, can you hear me? Hello, mate, can you hear me? It's the ambulance service, can you hear me?"
No response.
No response to verbal. Just going to unzip the top there just to reveal the trapezium and just give them a squeeze, one either side. "Hello, ambulance service."
No response.
No response. At this point, I've got an unresponsive patient, so I'm going to call for some senior clinical support at the scene.
That's 7 minutes away.
7 minutes away, thank you. Right, the first thing I want to do is a rapid assessment. So I want to have a quick look at the airway and the breathing and the circulation. So the first thing I'm going to do is a quick check of the C-spine. That all feels intact.
No C-spine deformity.
Okay, smashing. A quick check of the airway. Make sure that there's nothing in there, nothing that I can see.
Airway is clear.
Airway is clear. If there had been something in there, I've got options of using McGill forceps to remove it. If it's a liquid form, I've got the option of using suction or postural drainage. So the airway is clear. I'm going to just gently tilt the head back. I'm going to listen and look and feel for breath. And at the same time, I'm going to look for a carotid pulse.
So the patient is breathing and you have a pulse.
Brilliant, and I can note that the patient feels warm. So that's my rapid assessment complete now. I'm going to move on to my primary survey. And what I want to do is then move back to securing the airway whilst we continue the rest of the survey. I'm going to use an OPA airway, and I can measure the correct size of this by looking at the incisor teeth down to the angle, mandible angle. What I'm going to take is a second opportunity just to double check that airway is clear before I insert the airway and risk pushing anything further down the throat.
Airway is still clear.
Okay. I'm going to insert the airway using the correct technique, which is invert, insert, rotate and locate. That is my airway secure, and I'll monitor that as best at the breathing as I can through. I'm still noting now that the patient is airway secure. I'm going to look at the breathing. I can still feel breath on my face, and I can still note rise and fall of the chest.
You are getting rise and fall.
I'm using my supporting equipment O2 levels. There we go.
Your oxygen levels are coming in at 96%.
O2 is 96%, and the pulse rate is showing of
65.
65. Okay. So the oxygen is within realms. I would like it to be between 94, 98, preferably 96 to 100, so it doesn't score and use. If it had been a little low, I could consider using oxygen supplementary, and I'd use my JR Calc to see what I'm doing there. If I'm going to use that, I'd also consider using a nasal cannula on this. The options for the airway that I oversaw a minute ago is there is an option there to put a nasal pharyngeal airway in. Obviously I couldn't use the nasal cannula with the nasal pharyngeal, so I'd be looking something like a face mask for additional oxygen. But on this occasion I've chosen just to run with the oral pharyngeal airway. So I'm going to just take a good 30 seconds now, just to monitoring the rest rate of my patient.
Your rest rate is 22.
22. Smashing. So the rest were a little higher than I'd expected. I'd like them really to be sat between the range of 12 to 20. But they are slightly outside of that range. I'll monitor that, but continue the primary assessment. The next thing I want to do is have a look at the circulation for my patient. Watching my cable management, I'm going to place the blood pressure cuff on the other hand, on the other arm. I need to be mindful that there are no injuries to this arm, so I'm looking for any signs of bleeding, any of any deformities, if there's any med bracelets or med alerts on there, and no Libra.
There's no injury, no bracelets, nothing to stop you.
Okay. And we're running a blood pressure.
Your blood pressure is coming up at 115 over 72.
115 over 72. Cool. So I've got a reasonable blood pressure there. Bearing in mind now we're looking at circulation, I'm just going to consider both radio pulses.
Radial pulses are both present, both regular, and they are matching up with the figure on the defib.
Brilliant. My last check is going to be a central capillary refill. I'm going to choose the forehead, although I could option for a sternum as well. So I'm going to press for a good 5 seconds. 5.
Under 2 seconds.
Under 2 seconds. So capillary refill is within remit. The next thing I'm going to look at is my disabilities. So I will, on this occasion, going to have a look at the temperature. Check my patient's temperature to give me an indication of anything that may be going on that I can't see.
Temperature is 36.4.
And I'll take the opportunity to have a look at his blood sugars.
Blood sugars are 6.4.
6.4. And whilst we're at the top end still, I'm going to just check and see what the pupils and pupil reaction are like on my patient.
Pupils are equal and reactive, size 5.
That's brilliant. I'm going to have a quick look at the extremities now. There's a slight bit of exposure. I need to be mindful that we are in a car park. There might be onlookers. So I'm just having a quick look for any signs of pacemakers, med alerts, any signs of surgery. I've got looking at a rise and fall of the chest at the moment.
Still got good rise and fall of the chest.
And consideration at this point of blood on the floor and fall more. So I'm looking at obvious signs of blood on the floor, whether there's any blood in the chest, abdomen or pelvis.
There's no obvious signs.
And the long bones, that's fine. Quick signs of, I can feel that he's slightly clammy, but no obvious bruising, no deformities there. I'm going to just quickly move down to the legs. I want to have a look at if there's any swelling, bruising or any other early indication.
There's no deformity, no swelling, nothing standing out.
So at the moment I'm declaring my patient has a GCS of 3. That's based on the fact that there's no response on the eyes. Verbal response is no response either, and 0 motor responses. And currently I'm looking at a new score of 5. That gives me 3 for his unresponsive nature and 2 for the rest rate of 22.
Okay.
I want to move on to my secondary survey, but I'm just going to take a quick moment to check the patient's airway again and just review the O2 sats and everything of my patient.
So the patient is still breathing, there's no change in their oxygen saturations or their respiratory rate.
Brilliant. And a final check. Hello mate, can you hear me at all?
Still responsive.
Smashing. So, starting at the head end then, I'm just going to check around and look at the face. I'm looking for general symmetry. I'm trying to get some idea as to why this gentleman's on the floor. I'm looking at the orbits on the eyes, the cheekbone, the jawline. Does it fit? Does it match up? Any sort of indentations on the forehead. We're going to move around out of sight now, around the back of the head. Check that C-spine again. We really can't feel anything untoward there. Checking the back of the head, looking for boggy masses, indentations.
There's no, your face is nice and symmetrical, no boggy masses. No.
There's nothing on my gloves to indicate any bleeding, and I'm just going to have a good check in each ear, looking for any signs of blood, bleeding or clear fluid that may be draining from inside the skull.
No obvious signs of anything that's untoward, no bruising, no deformity, no boggy mass and no CSF.
Brilliant. What I might do at this point is consider an ECG, because I'm still trying to find out as to what reason this gent is on the floor. I'm checking the clavicles, now the shoulders, looking for any signs of deformity, any irregularity. Just checking the top of the shoulders there and underneath, looking for signs of blood. I want to expose this gent's chest and torso just while I do a bit more of an assessment. I'm having a good look at the chest now, I'm having a look at the rise and fall. I'm having before I start palpating, I want to have listen to his 8 segments on the front. Have a look on the side, I'm just looking for sort of any indication again as to what's going on in here. So that's my 8 segments complete.
You've got bilateral air entry going in, no adventitious sounds, no wheezes, crackles, just good air entry both
Brilliant.
sides.
And it's evident I've got no chest flaming as we just established. I'm going to move on to the abdomen now. I just want to palpate the abdomen. I'm looking for anything that feels like it should be in there, any firmness.
The abdomen is soft to touch, there's no distension or discoloration.
Okay. And then a good feel around the back, looking for any other indication that what might be causing my patient to be on the floor. And I'm checking my hands for blood.
Bloods are clear, no obvious issues standing out.
Okay. Let's cover this gent back up again. I'm going to leave the head end and investigate the pelvis below. So I'm just doing a final check on this patient's breathing and his observations.
No changes in your observations, still breathing, no issues with airway.
Okay, we're moving down now to the pelvis area. I'm looking for initial signs visually if there's been any form of incontinence. I'm just going to pull this down to reveal the pelvic line, and I'm just looking for anything that's not symmetrical, anything that looks untoward, any sign of bruising. And I'm not going to push down on the pelvis, cause any further potential injury, but I'm just feeling generally to see what we can find.
There's no incontinence, there's no obvious deformities you can see, there's no obvious markings or bruisings, everything looks equal.
and I'm just checking that there's no prioplastism for
There is not.
belting. Happy with the pelvis area now. Looking at the long bones in the legs, and before I start getting hands on, I'm looking for if there's any sort of lengthening, shortening, anything rotational which might indicate an issue with the limbs or the pelvis. A quick check-up, my patient is still breathing and I've got obs.
Observations are fine, airway is open and the legs are equal length.
Okay, again just checking these limbs. No deformities, checking for deformities and checking for blood.
Yep, there's no blood, no issues there.
That's fine. Looking at the foot again, removing any footwear if necessary. I'm looking for any deformities in the feet. I'm looking for any indication of track marks between the toes, and I'm looking for the pedal pulse.
You've got a pulse present, there's no track marks.
Moving over to the other side, I'm going to complete exactly the same process again. Feeling for deformities, checking for blood or fluids. Checking the foot for deformities or breaks, track marks, and checking for a pedal pulse.
Pulse is present.
Okay, I'm happy with my long bones now. I'm looking up towards the head as I've been away. I'm checking my patient's breathing and their obs.
Obs are fine, airway is still picked up.
Brilliant. Final checks now onto the long bones in the arms and the hands. I'm looking at the hands for track marks, any indication as to why my gent might be here. Again, looking for a med alert bracelet. Any feeling of anything untoward, signs of liquid blood, nothing.
No, nothing to cause any concern.
And final arm.
Arm is clear, no injuries, no blood, no track marks.
Okay. So that's my primary survey complete. What I want to do now is have a look at the back of my patient.
So for the what are you going to do next then?
I'd like to do put them in the recovery position, so I can also take the back and look at the pelvis from the rear.
For the purpose of the video, I'm going to be your patient and you can put me into the recovery position.
Thank you. Let's walk that leg right up, nice and stable. Make sure you're comfortable on the front, that your airway's open should you vomit or any fluid come out of your mouth and it doesn't cause any blockages. I'm just going to also take you back. I'm looking for your points on your back now to also take, just listen for lung sounds. And then just a final check now, we're looking at the rear of my casualty, looking for anything untoward with the pelvis, the rear of the long bones that we've not visually seen yet, and maybe the sort of the buttocks area.
Okay, so your paramedic has arrived. What would your handover be?
I've used the SBAR communication tool. I'd like to welcome my paramedic.
You can take a seat, you won't need it.
Yeah, I'll do it here. Close to the camera there.
Okay.
So I'd like to let you know that this is a 45-year-old male found collapsed unresponsive in a car park. The scene is safe. The patient has been unresponsive to me for the full time I've been here. We've run through their observations. Their observations so far are that the O2 is 96%, pulse rate is 65, rest rate is slightly high at 22, BP within range at 115/72, a temp of 36.4, eyes are equal and opening, BM 6.4. The patient has a GCS score of 3 and has a new score of 5. That's scoring 3 for the unresponsive nature and 2 for their rest rate. I've been monitoring for the time they're here. There has been no change. I have considered the ECG for them, and my intervention so far have been the inclusion of the airway. I would like you to take over, and I'm happy to support you with your next move.
Yeah, no problem. Yeah, that's spot on. How do you think that went?
Okay, I think I've got everything in there. I think I might have bounced auscultation a bit.
There was a little bit when, you moved around on the auscultation, you kind of hesitated a little bit on that, but at the same time, I think that was really good.
Okay.
I think that was superb. I think
Oh.
it was really, really good. Yeah, from my point of view, you came in, you know, it was, I've changed the location, but so I picked a location. You thought above and beyond with the dangers. To be honest, you were thinking about the high vis, you were thinking about cars, things like that. So really good awareness of safety. You give a good commentary on the patient as you were walking up, and you were verbalising what you were talking about, what you're looking for, what you're interested in. I found it was particularly calm and methodical throughout. You were hitting every step as you were going through. Like I said, when it came to, there was a little bit of hesitation, but I don't think there was there weren't any delays with it. I think there was just what am I going to do? I'm going to auscultate or talk properly. But other than that, as you were talking through, your rapid ABC really good. You've updated, you updated controls you needed to. You put the OP airway in. I suppose, I think you realised you'd not mention MP a little bit later, so you mentioned that later on. But you gave really, really good detail with it as well. You said, well, if I've got an MP, I wouldn't really be looking for a nasal cannula. You gave really good information around that, showing extra understanding. So I was really happy with that. Because we would have accepted at the end, is there anything you could use? I could use MPs and that. But you showed that extra thinking, you showed how you'd manage it, you know what's going on. That you get in an observation, you're thinking, I've got to manage that. I said, when you realised the respirator was up, it wasn't just the respirator, it's a little bit elevated, that. So you're acknowledging it as you're going through, and I really like that. Really detailed, considered the ECG, we consider it. You've made reference to us being in a public place, so you know that was constantly in your mind. Really good. So all your primary, really happy with that. You went back up. I liked that when you were reassessing, you weren't just reassessing the airway. You're making reference. I'm going to reassess the airway, and I'm going to have a look at the obs. So again, it's showing that thinking, that linking everything up. It's not just, I know I need to reassess, because that's what the process is. I'm reassessing the airway and my obs, I'm happy with my obs. So yeah, really happy with that. Like I said, methodical all the way through, really good commentary, which is probably one of the harder things to think about talking about it and doing it. But really happy with everything that you did there. Your recovery position, you say you've listened to the back, you've made reference to loads of elements that you'd check on me on the back. And your handover was good. The information's there. I've really not got much to say really to make it better for you. What I would kind of indicate is, when we're talking about priapism, I know it comes up because we're talking about this. The chances are, when we talk about the priapism, there's likely to be other elements involved that would make you think, because it's generally going to be trauma, brain injury of some sort. What are those two? Spinal injury, brain injuries that might cause it. And the likelihood is that you're going to have gone to some sort of trauma, something indicating that already. And then if you go, hang on, if they've had a fall and they've got a priapism, that indicates actually it's a strong indication that there's something serious going on. Making reference to it is that, it's absolutely fine, but it's probably not going to, it's not something that you would, if all the obs were fine and it was there.
And you've got pedal pulses as well.
Yeah, it's everything's as it should be. So that's fine. That's the only thing I can really mention on that. But really good, well done. If that's how you're going to be doing your OSCEs, then you smash it. Well done.
Thank you.